to that conversation go even longer. It was fantastic, and I know we'll be bringing more and more content your way as people are sitting back going, man, what do I need to do? Sarah Wright has truly, she's just learning how to do some of this stuff, right? Tegan's gonna tell you, hey, it's tough going out there and building some of this, and Cassie's gonna tell you, hey, listen, I like when I do TikToks because I can make it rain, right? So all of those things, people are gonna have different things that are gonna go on, but I think the best part is figuring out what works for you and your business. You're going to hear this later on in the day, even when Ashley Livermore and you hear some of our top sponsors like Amy Holscher go out there and deliver, they're going to tell you that people today are looking for all different types of ways to do business. I think the days of doing it one way are definitely changing. Well, I know one thing that's constantly changing, and that is sexual health information. And we're so lucky that we have an awesome foundation here that Patty started, which is called the Patty Brisbane Foundation for Women's Sexual Health. And if you don't know, the cool part is we have so many doctors that constantly are bidding to be on this board. This board is out there finding and working with universities and working with programs all across to better women's sexual health. So right now, we're going to do a little panel with our doctors from the Patty Brisbane Foundation to you to give more information to help guide you and help give you information for your parties and also for future information for your clients.
Thank you all so much for tuning in and prioritizing your business. Your continued education is proof that your business and clients matter, and you want to be there to support them. And what better way to support than with sexual health information from our esteemed PBF doctors? So Dr. Critchman, let's start with you. Can you introduce yourself and tell them what you do on a daily basis?
Well, hi, Patty. Thanks so much for having us today to talk about so many important issues in women's sexual health. I'm a sexual medicine gynecologist. I am in clinical practice as well. I have 4 offices that I rotate through. I see high-risk women who are at risk for cancer or those who are dealing with cancer on a regular basis, plus those who have chronic medical conditions. In addition, I'm a professor at the University of California, Irvine, and I also supervise the residents. But one of my most honored positions is I am the chair of the medical board of the PBF. I get to work with wonderful women like yourself and the rest of the MAB to help, bring women's sexual health to a new frontier and dispel some of the myths and mysteries and really empower women on a day-to-day basis to take control over their bodies, their sexual health, and their general health in general. So it's really exciting to be here with you to chat about some really important topics. And thanks so much for having us.
Thank you. Cheryl?
Hi, Patty. I echo Michael in saying what an honor it is to be here. I love my colleagues and I love the topics and the importance to women's sexual health. I am a clinical psychologist. I have a division of behavioral medicine in an OBGYN department, which allows the sort of the biopsychosocial model, which we'll talk about later, of multidisciplinary approaches to women's health and women's sexual health. So I provide the psychological help to women who have GYN and other medical issues. I'm also a professor in the departments of reproductive biology, psychiatry, and urology, all important areas for women's health, at Case Western Reserve University School of Medicine. And I'm the newest, maybe not youngest, member of your medical advisory board. So I'm so pleased that you have included a psychologist. Thank you.
Thank you. Christine?
Well, hello, everyone. I am also going to echo the words that have been said. I'm very honored to be included in this esteemed board of colleagues. I'm honored to provide education to women that hopefully can then be disseminated even further. I think that's the greatest power of this Women's Health Foundation, is the ability to disseminate the education. So I'm very grateful to have that honor. So a little bit about me. My name is Christine Vaccaro. I'm fellowship trained and double board certified in female pelvic medicine and reconstructive surgery, which is just a long fancy name to say urogynecology. So I deal with women's pelvic floor disorders on a daily basis, which includes their sexual health So that is what I do. I'm an associate professor of obstetrics and gynecology. Happy to be here.
Sherelle?
Hello and good morning. I'm Shirley Glazia, and I am the Director of Female Pelvic Medicine and Reconstructive Surgery for MedStar Health in Washington, D.C. I'm also a professor of OBGYN and urology at Georgetown University School of Medicine. And my passion is educating women about pelvic floor issues. In addition to being a surgeon, we are intimately involved in training the next generation OBGYN and urology residents. And I'm happy to say that this past Friday was the big match day, and all of my mentees, we had 12 go into OBGYN, they all matched. 6 were particularly, I was very close to it, and that's exciting. So in addition to talking to you as patients and as advocates for women's health, we'd like to train the next generation of OBGYNs.
Thank you. Kathleen?
Hello. Well, I'm very excited to be here. You all consultants are the grassroots for all of this education. You're the one who can take that client and help them through many issues with sexual health. And so by having this opportunity to provide this education is very near and dear to me. I'm a doctor of physical therapy and board certified in pelvic health. I've been doing pelvic health for 30 plus years. And presently I'm the director of pelvic health education and program development in Cincinnati, Ohio.
Wow, I'm going to tell you, I am just so honored to have all of these doctors talk with us today. They are committed to giving all of you this information and resources that you need to help your business and to help your customers thrive. I'm proud of all of you. This is amazing. Thank you so much for being here. We're going to start right now with Dr. Critchman. Our partners are hearing more complaints from women being concerned with the way that their genitals look. Many are inquiring about labiaplasty, laser use and its safety, genital piercings, and other cosmetic concerns. Can you talk to us about these cosmetics and what it has to do with sexual health and the advice that you can give with those who are struggling with this decision?
So Patty, what a very important and timely, topic. I think, it's very, very important to address these issues. And I think for me, the number one issue is about education and really understanding, that we need to empower our women, our young girls as they grow up to understand what their genitals are, to use the right words, to actually take mirrors and show them what their vulvas and vaginas are. Very often I know many of the board can attest to the fact that people will say it hurts down there. And we're like, where? Your knees, your ankles, they group everything together. And understand that the first and foremost is about education, and understand that every vulva is different, just like every face is different. And very often, I think that the big issue is, for me, is the why. Why is somebody coming in with this concern? Why are they hearing it? Is it the woman themselves, or they've heard comments from other people, their partners, and what have you? So first and foremost, I think the most important thing is about educating women about their anatomy, that it's normal. It's normal to have vulvas of all different shapes, colors, sizes. Right and left sides don't have to be equal. There's a great resource. I think, every woman should probably get that at some point in their life. It's called Viva la Vulva. It really is a great book, which really looks and shows women that there is asymmetry, that there's difference in colors, sizes, textures, and really understanding the why. Now, let's flip back to this concept of autonomy. So autonomy really, for me, is the number one decision maker. That is that women have self-determination, they have autonomy, they have the ability to control their body. And if a woman is coming in, and I really believe that if she is assessing her own sexual self-esteem and she's saying, look, I'm really uncomfortable, or there's a functional issue, because there can be functional issues with asymmetrical or very long vulva, that the vulva lips are rubbing when they're walking and what have you, or they're very concerned about the cosmetic for themselves, not to please a partner, not because they've heard some other things. So very often the first thing that I do is tell me why you're here, why you're concerned. And then, if the discussion goes down the point, well, my partner said I look different or look strange, and or every other partner is normal, then we have a different kind of discussion versus if she says, when I'm having intercourse, my labia are so long, they're being dragged into the vagina and it really causes a lot of pain. Or, I'm an avid jogger, and I can't, be comfortable in the things that I love to do, and I'm really uncomfortable. So I think there is a difference between an aesthetic issue, a cosmetic issue, and a functional issue. And really the clinician, an experienced clinician. And I think many of the panel will attest to that we need people that know the vulva, that know the vagina. Women's healthcare professionals need to take back control of the vagina, because very often there's undiagnosed issues. They're not being assessed properly. So when you come to labiaplasty, again, in experienced hands, a proper procedure, certainly everything can go well, but there's also issues. There can be bleeding, there could be infection, there could be changes in sexual function. Remember, the vulva, the lips of the vagina, many women consider this a sexual organ. During sexual arousal, they get engorged, there's blood, it may affect your sexual response, and women are not being taught appropriately. So I think there's a lot of reasons for women to learn about their body, become empowered, and under certain circumstances, they may want to get a labiaplasty or a reduction and what have you, but really go to experienced hands, go to someone who knows the vulva, and ask the right questions. I think those are really, really important issues. But let's move on to this other, what I call femtech, the lasers, the radio frequency, all these new experimental things, right? I was just reviewing an article on light therapy, that it was heralded as the greatest thing. I had a woman come in, she spent over $3,000 to get light therapy, and there is no data. So what I am, I came out really hard, and I know Sherelle will agree with me that I came out really hard on the lasers and radio frequency, because we are data driven. We really need to look at the, at the science behind it. And, I think, for me, I've come full circle. I think for lasers, there's emerging data to support their use in a variety of different conditions. There was just a great, meta-analysis review just this last month in the Journal of Sexual Medicine. It came out, it looked at CO2 laser treatment for vaginal dryness. It looked at a lot of studies, and it shows that there's excellent promise. But again, let's back up a little bit. Experienced clinicians knowing how to evaluate and assess the vulva, the vagina. And remember, Patty, I always have this saying, when you hold a hammer, everything looks like a nail, right? So we tend to realize that clinicians that have lasers want to treat lasers. And I think we treat with lasers, and we've come full circle, right? I remember way back when I had a laser representative come in, and it told me it made a dry vagina wet and a wet vagina dry and a tight vagina loose and a loose vagina dry. And I said, give me the short list. Tell me what it doesn't do. Follow the science, follow the data, go to good academic centers that have clinicians that are well experienced, well versed in this process. And I think that's a really important thing. Data is changing all the time, and academic clinicians tend to be much more up to date. They tend to be involved in clinical trials. But, I think it shows excellent promise. The science is there, the data is emerging, but this is over time. So, don't jump on the bandwagon to the next best cure. We as academics and women's health, we're not holding the secrets. fast to treating dryness or treating, sexual problems. We share data as a community and look at the value of the science, right? So again, you can look at science and see, maybe it's not the best article, but again, look and do research. I think it shows excellent promise. And, before we jump into genital piercing, would love to hear Sherelle's opinion, because I know we have sat on the podiums together. We have talked about this. I wrote articles called The Techno Vagina, Rethinking the Techno Vagina. I was one of the first people to write about the complications of laser early in the experience. And again, I think as time unfolds, we learn more as scientists and as doctors, and then we can incorporate this into a clinical experience much better. So Sherelle, please, I'm dying to hear what you have to say.
Well, thanks, Michael. I agree with what you're saying. I think one of the issues that has spawned this industry is the hair removal business. We did a study, I want to say 10 years ago, where we just actually asked people on the street randomly, and I think we went to the undergraduate campus, and how many people were actually using some type of depilatory or pubic grooming, and it was over 85%. So when you remove all the hair, it looks different in the landscape or the manscape. And so now, and Cheryl and I have written about this as well, about the perils of the idealized vulva, and which is what people are seeing on, porn magazines, internet, where, basically it looks like a Barbie doll when you're not supposed to have very big inner lips that are called the labia minora, and they're not supposed to protrude past labia majora, which is totally, in fact, not right. And what happens, I'm very concerned, particularly when young women want to have a certain look because they feel ashamed or they've been shamed, body shamed, that they have to go ahead and start cutting things off. I worry 20, 30, 40 years down the line, what's going to happen when lips naturally resorb, or potentially nerve damage can occur to the very delicate structures, because the labia minora actually conjoined right under the clitoris. Going too high, and I'm going to be talking about orgasm, one of my favorite topics, next. If you get too close to that, you can damage some of the nerves. So be careful. Now, with regard to the wands, the wands and the lasers, yes. The problem with most of this is that most of the findings are small, with very little follow-up and no comparison, i.e. no placebo or sham. And I'll credit Dr. Critchman for doing one of the best trials looking at radiofrequency with a sham device, but very few exist. You talked about the Australian study, which showed no difference on dryness. Just be careful, buyer beware. There's a lot of marketing ahead of the science when it comes to these kinds of techno vagina issues.
Right. And I couldn't agree with you more. And I would say follow the science and look at the science and what have you. What about, the other topic, Patty, you wanted to kind of briefly talk about is piercings and what have you. And again, I really want to encourage women to kind of look at the why. Why are they doing this and what have you? I certainly have a lot of women in my clinical center that have genital piercings. They have their clitoris pierced. And again, many women will come to me and say, well, I've heard on the internet that, if you pierce your clitoris, you're more likely to improve your arousal or improve your orgasmic response. And they really haven't had a proper evaluation or assessment or what have you. So again, if they're looking for an aesthetic, that's one issue. If they're looking for a functional change, that certainly is another issue. And, I can't stress the importance for the choosing your right healthcare team. I have, because I'm a tertiary referral, I have had women who've had experiences with untrained clinicians who hang up a shingle and they have no training in looking at the vagina or the vulva. They miss very clear diagnoses that have other simple treatments and what have you. So I can't stress the importance to build a proper healthcare team, do your research. And for some reason, we know that women, they will do a lot of research for their children, they'll do research on for their husbands or their partners, but when it comes to them, they're very much, they may be influenced by other people. And I really want to stress the fact that I want to empower women to do the research themselves, seek out, women's healthcare professional experts, ask the right questions, look at their training, ask how many procedures they've done. And a good doctor is never afraid of a second opinion. And I see women that have come to see me for second, third, fourth opinions. And I think it's okay to gather information because this is your body and this is your sexual response. And I think it's really important for women to be empowered to take back control of what I would call their sexual self-esteem. And understanding their anatomy is one of those. Understanding how their response is another. So not necessarily that your response may be increased if you have a clitoral piercing. And like every kind of piercing, there may be issues of infection, inflammation, hard time to heal, scarring, and these are lifelong challenges that you will have after this intervention. And remember, the clitoris is really a vital component, one of many components to your sexual response. And you really want to be very careful before you do an intervention that may be permanent and irreversible. So get your information, ask questions. And if you're not in a comfortable environment where you can feel empowered, then it's time to change that environment. And when I say environment, it may be your clinician, or it may be your relationship as well. So I think it's really important for women to stand up for their rights, stand up for their sexual rights, and really be empowered over their anatomy and sexual response.
Okay, let me ask a question. You keep saying, get information, go do your due diligence in finding out. Where are they going to go to find this out? Where are they looking?
So, I think the first stop really, when I'm biased, it should be the Patty Brisbane Foundation. We have a great resource center. I think if you are looking, you should be going to academic centers where you have professors who are really well versed in this. You can do research. We are cutting edge. So we are cutting edge in terms of science. We fund scientific programs that are looking at laser. So I would start there and look at those clinicians who have submitted research, who are really on the cutting edge. They're at the cusp of the research and the details, and really ask for information. There's societies like the North American Menopause Society. There are societies like the International Society for the Study of Women's Sexual Health. But I think it's really important to gather information. Sometimes it's okay to ask questions, and we have a resource center. So, I think for all those listening, it's okay to say, I want the Patty Brisbane Foundation to be the first stop. And we have an amazing panel up here. We have an amazing resource center here. And, we have that network to be able to shuttle somebody to the right person in the right location and really afford them the ability to get proper information. And in today's
Michael?
day with telehealth, it would be amazing. Yes.
Michael, I'd like to jump in because Patty's question is so important, particularly for the consultants, because women don't know where to go for information.
Right.
And so where they end up going is actually God knows where. They're off in the internet wilderness and finding a lot of information either through friends or crazy websites, and they're given misinformation. So we are responsible for helping direct them to accurate information, because not everybody has an academic resource, or you say,
Right.
Go to an academic center, that they don't even know what that is. So I think the consultants can maybe help guide women to either the websites of those organizations you mentioned, like NAMS North American Menopause Society has a patient-facing website, and the International Society for Study of Women's Sexual Health will have patient-facing websites that can give digestible information. And the Patty Brisbane Foundation has digestible information, because too much science is just going to overwhelm even even I get overwhelmed a lot reading things. So we want to make sure it's something they can understand and not just kind of say, oh, forget it, I don't get it.
And I jump into,
Yes.
because when you're looking at when you're looking at the claims, it's really important that you understand who's funding that study and what the outcomes are, because people say this is 80% effective, and that's just like based on a biopsy or some like random number, not an outcome that really matters to a patient. So that's really important when trying to read between the lines, not just the sound bites or what you see on the advertisements in clinic offices, on the internet, et cetera. The American College of OBGYN is another great resource with frequently asked questions, patient-facing pages about what normal anatomy looks like and the variations. And, having served on the patient education board for ACOG, I know that this is something that they need to get that information out, because it has been vetted with a lot of experts as well, as the Patty Brisbane said.
Sherelle, I'm surprised actually that as you're talking about lasers and these radio frequency devices, that one of the things that women are not informed about is the safety and efficacy of vaginal hormone therapy, right? So when you're thinking about what would you use and what has science behind it to prevent, and I know Dr. Vaccaro is going to talk about genitourinary syndrome of menopause, but those are the women, these postmenopausal women who have the tissue that essentially atrophies and the dryness and the pain with sexual activity. We have safe and effective treatments that are data-driven, right? And that women are afraid of because they're getting misinformation. And so, on the other side of, do the lasers need more data? Absolutely. But we have safe and effective treatments so that women can have pain-free sexual health and healthy vaginas.
And Cheryl, that kind of ties into the concept of, follow the science and ask questions. And, and very often what I see is women will say, I never knew there were other options. It goes into this concept, if you are holding a hammer, everything is a nail. So, and we need healthcare professionals who are trained and focused on women's health to take back control over the vagina and know all the treatment options. Because very often I will have, as a tertiary referral, have women come in and say, I got a laser and now I'm still in severe pain. And they said, if I use vaginal hormones, I'm going to get, a malignancy or cancer. And I end up spending quite some time talking about the safety and efficacy and the long history of minimally absorbed local vaginal estrogen. So option counseling, certainly I agree with you, and comprehensive option counseling. That includes non-hormonal, it includes hormonal, it includes non-hormonal alternatives, oral medications, all different types of delivery systems. And I think people shy away from that because it is a detailed conversation that you can't have in a 30-second interlude with a patient. So again, all tying together that people need to be educated about option counseling, about their clinician, building a right team, and really being understanding that these are not without adverse events. And I think your point is very, very well taken.
All right, are we ready to move on? Anybody else? Okay. Dr. Kingsburg, women are having more concerns with their libido more than ever. What do they need to know about libido in today's world, and how can they address some of the concerns?
Well, women are more concerned than ever about their libido, or what we would call sexual desire, but honestly, they've been worried for a long time. We just haven't talked about it. It's only now that women are coming forward to say, hey, well, what about my sex drive? I want a healthy sex drive. I used to have it, it's gone, where did it go? We now know that what we call hypoactive sexual desire disorder, or loss of libido, is the most common, most prevalent sexual problem for women of all ages. We can estimate about 1 in 10 women, so on this, whoever's listening, 1 in 10 of you are struggling with a loss of sexual desire, and it's distressing to them. So we know actually about 43% of women in the US can report decreased desire, and about 1 in 10 are distressed enough that they would want to treat it. And that would be called hypoactive sexual desire disorder. And I kind of alluded earlier to the idea of a biopsychosocial model, which is a mouthful, but it really reflects the fact that sexual health is best understood from looking at sexual health or sexual problems from the combination of biologic factors that can contribute, psychological factors, sociocultural factors, and interpersonal factors. And that is particularly true for sexual desire. So if you think that there are biologic factors contributing to low desire, that could be a neurotransmitter imbalance, it could be loss of testosterone as you reach menopause, then we think about treating that biologically. We have 2 FDA-approved treatments for loss of sexual desire in premenopausal women. We have 2 now. And guess how many, treatments we have approved for men? We have over 26, but we have two FDA approved, but for loss of desire. And for postmenopausal women, we have off-label use, but absolutely data-driven, evidence-based testosterone for postmenopausal women who have loss of desire. That's the biologic issues. If you have underlying health conditions, if you have depression, by the way, one of the most common symptoms of depression is loss of drive. So you want to make sure that you're treating the underlying depression or other medical conditions that might be causing sexual desire problems, right? So on the biologic side, we either treat an underlying medical condition or we have some pharmacologic treatments. Psychologically, again, depression, anxiety, performance anxiety, all can contribute to low desire. But the other concept is the interpersonal component of sexual desire. Somebody could have all the biologic drive, they have great appetite for sex, but if they don't particularly like their spouse, they're not going to want to be sexual with that person. So you have to think, if you are out there counseling women, who say, I don't really have much interest in sex anymore, ask them, is it that they just don't have the appetite anymore, right? Spontaneous drive, they don't think about it, a romance novel doesn't turn them on anymore, or is it that they have drive, but their partner is really kind of not interesting to them? And that's the key to which kind of treatment you're going to approach. We know that women in longer term relationships, for example, kind of struggle with sexual boredom. We all are sort of prone to that. You have about a 2-year window in a new relationship that creates that passion, the romance, the mystery, right? That horniness that we all kind of strive for. And after that, you go into these long-term relationships where, you're kind of a little bored. And so I think, as consultants, you are the key to fixing this for so many women, educating them that it is the case. There's nothing wrong with their relationship. There's nothing wrong with their relationship if they're thinking they're a little bored and they're a little, things are humdrum. It is time. The smart couple in a long-term relationship knows they have to add in spice. They have to add in a little novelty in order to create that mystery and the challenge when you live with somebody day in and day out, right? So this is the perfect opportunity to create some of the passion that gets lost in that long-term relationship. And so that's where sex toys come in, experimentation, picking a different room in the house or a different time of day, not necessarily a different partner. That's for a different discussion. But what you want, and most people really want to maintain, they love their partners and they say, this is my partner, this is my best friend, this is the person I want to be with. Why am I a little bored? And that's because with the long-term relationship, there is definitely going to be that sort of boredom. The other thing that happens is, and I have to say, and it's not always heterosexual, but there is a desire discrepancy that often occurs. Look, no 2 people have the same sexual appetite, right? No 2 people. So whether it's 2 women, 2 men, a male or a female, you come in with a difference. And so if one person has the drive and wants to be sexual, let's say 4 times a week, and the other person is like 4 times a month, that discrepancy can create a problem because, look, the person who has higher drive is like, well, to the person who has less drive, how come you're the one that always gets to say yes or no whether we're having sex? Well, that's because their appetite isn't as strong. And so the person who's, wanting it all the time would always say yes. And so there becomes sort of a resentment or feeling of being controlled. And for the consultants, it's helpful to educate women that that discrepancy is not a problem. It's just a discrepancy, and you learn to negotiate. How often would you be able to compromise if you have less drive, and how much would you be able to compromise if you have more drive, to sort of create a happy medium? It's how I describe, sort of ice cream. I personally have the drive to eat ice cream 7 days a week, maybe even twice a day. But, maybe my partner, would be happy with it once a week. And so we kind of compromise with a couple times a week so that, too much of a good thing is not a good thing. For some people, eating ice cream every single day would give them a sugar headache or make them not appreciate it anymore. So it's recognizing the compromise there and helping women to understand that discrepancy is not conflict, it's negotiation, right? And please remember, if you are on medicines, ask your clinician whether that may be a culprit in your loss of desire. Antidepressants, the selective serotonin reuptake inhibitors, are total culprits when it comes to decreasing desire. They can help treat mood disorders, but sometimes they can cause problems with sexual function. Even antihypertensives or things for blood pressure can cause problems with arousal and, to Sherelle's topic, orgasm. Right. And so can the SSRIs. They can create problems not just with drive, but with orgasm. And so before you start, going down the wrong path, one of the simplest things to do is ask your clinician, who, by the way, may often not even know or care that there are sexual side effects. So read the package insert too. That you can do and see, look at that. It's a sexual side effect. Maybe I should ask about a change. So those are some of the questions.
So let's say that you, as we've spoken earlier, that not everybody's desire is the same, right? So let's say she does want to have sex 5 times a week and he only wants it 1 time a week. So with her using a bedroom toy, let's help her take the guilt, or him take the guilt away, that, you know what, just because you don't want it, I desire it. So what do we say to those people out there that have this desire? Should they self-please?
Well, can I just say what a gender difference there is? There is a double standard. We have for generations assumed that men will masturbate, and that is not about, sort of denying their partners or cheating on their partners. Right. And so it is absolutely the same. When there is a desire discrepancy, women should be encouraged and empowered to self-pleasure, and using toys is certainly an easy and helpful way. And incorporating toys into the bedroom, certainly, but also on their own. There is no reason, and that is not considered essentially cheating. If your drive is higher, it is the way to compromise. We talk about it all the time with men, and it absolutely should be the same with women. There's always the worry, and I hear a lot of men worry, well, what if my partner likes her toy better, right? And what if she becomes dependent on it? And I would say, well, it's a good challenge for him, if it's a him, to be able to figure out, well, what is this? It's not a toy. It is about lovemaking. Orgasm, and Sherelle, we will finally get there. Orgasm is not the only thing that lovemaking is about. It is about the intimacy. It is about the fun. It is about the pleasure. Whereas, men are going to, or partners will worry that their partners will become so dependent on a toy and a device. That's a means to an end. It is an addition and an enhancement. It is not the goal, right? And so I think that's so important for women and couples to recognize. And by the way, we have data, we have scientific data that women do not become dependent dependent on their toys or a vibrator for orgasm. They don't. If they were only using vibrators throughout their lives to reach orgasm because that was how they worked, then that would be normal, that they don't develop a dependence. And women who did not use toys and could achieve orgasm through manual stimulation or intercourse, they do not develop a dependence if they add in a toy. So can I please reassure everybody out there, there is no addiction, there's no dependence on toys.
Love it. I think a lot of our partners out there need to pay that forward when they're speaking to other women, that you cannot develop a dependency. It's nice to have, really
Right.
nice to have.
It's an addition, it is not an addiction.
There you go. Does anybody have anything else to add?
No, but I agree that hotel sex is the best. And then you have to have really good sheets though, too.
Yeah.
Nobody scratchy sheets.
And Patty, I think what we need to also do is normalize the concept of using a self-stimulator. And again, we talk a lot about empowering women, and very often women are shamed and they feel like there's something wrong with them. And that attitude is from ignorance, from very often from their partners. Why do you need that? I've heard that all the time in my clinical experience, that women are embarrassed. So normalizing it with fact, normalizing it that this is part of anatomy, that there is nothing wrong, I think is really important to take that shame out of being empowered over your sexual response, and really, dispelling the myths. And some of these are perpetuated by their male partners. I'll never forget this. When I was early on in my career, I had a woman come in with her partner, and the partner said, fix her. There's something wrong with her. I've been with thousands of women and none of them needed a vibrator because I was like so great in bed. And, this turned into an educational session for both him and her, and really understand that many women need direct clitoral stimulation. Many women enjoy sexual pleasure during intercourse, but are not orgasmic during intercourse. And, a vibrator is a normal adjunct to the sexual experience, and we need to destigmatize that. And I think it's important. The consultants have a great opportunity to normalize and talk about it as really an extension of your sexual experience. And let's also remember that men also can use self-stimulators. There are vibrating C-rings. Men very often enjoy that. And there's a lot of data on men and sexual pleasure and vibrators. And it's just a lot of cultural issues that they are, confined by these societal myths that, if you're a true man, you can, make a woman have an orgasm and you don't need any accessories. Well, let's wake up and embrace fact and, dispel the myths and get rid of this fake news, and really try to empower women to have control over their bodies. I think that's really super important and really important message.
I have another like corollary and Dr. Kingsburg, because as couples age and health issues, whether it be, prostate, breast cancer, erectile dysfunction and the dryness that occurs, that the desire, because it's associated with pain and or shame, particularly with erectile dysfunction. And I want to even bring out there pelvic organ prolapse for women when, organs are falling. Everyone thinks like, things aren't functioning well. Then they don't have the desire. Like, what tips and tricks do you have? Because this is a natural part of aging, but there's other things that you can do for sexual health and well-being.
Well, not only that, but it actually wakes couples up when they can no longer rely on 10 o'clock on Saturday night, we're going to have intercourse in the missionary position. which then they don't even pay attention to each other when they actually have to work at figuring out what's going to be erotic and helpful and work. Now it creates a whole new lovemaking. So sometimes taking intercourse off the table is hugely helpful. So to your point, Sherelle, sometimes men can no longer have intercourse because their erections aren't working well enough, and sometimes women, because of genitourinary syndrome of menopause or prolapse or other things, that intercourse is no longer comfortable for them. It helps them have to, sort of renew how they're going to interact together, and back to sexual enhancements and toys and vibrators. And Michael called them self-stimulators. It's not just self-stimulators. These are, stimulators for each other. So while you can use it by yourself, you also want to bring it into the sexual realm. It takes the pressure off of a male partner to have to insert himself if he no longer can, because now you have many things that you can insert. If that's how she enjoys sexual pleasure, by all means, there are many ways to have penetration. And if penetration is no longer what is pleasurable or ever was pleasurable, by the way, 40% of women are reliably orgasmic using a vibrator. Using a vibrator with clitoral stimulation. The majority of women are not particularly orgasmic with penetrative sex. That just isn't how our anatomy works. And so to validate, to Michael's point, that to use a vibrator or to use a clitoral stimulator is normal for you, and that it doesn't mean that it's a problem. And to Michael's patient, we call that delusion disorder on the partner's point, where he thinks he's, creating multiple orgasms for his partners who are, probably faking for him. And that's why he doesn't have them anymore. These are, the normalcies of women, that clitoral stimulation is key, that particularly as we age, intercourse and penetrative sex isn't usually the most reliable way, and it creates novelty and enhancement and eroticism to have to think out of the box.
We're ready to move to the next question.
Yeah, I'm ready. We've been ready.
You've got to be ready, because this was for you, Dr. Iglesia. There are a lot of questions from women who can't experience an orgasm, even using an enhancement or even through foreplay. What are some of the suggestions that can help them accomplish this? What's going on?
Okay, so I think we're going to the meat of the matter here when we talk about the clitoris. And so there is such a thing as primary anorgasmia, and Cheryl can talk about that. That's a diagnosis where you've never had an orgasm. And then there's the secondary anorgasmia, where you've had orgasms in the past, but you're no longer having them. So while Cheryl was talking about the biopsycho, more psychosocial, I'm going to focus more on the bio part and on the anatomy and physiology of the sexual response, because I think that people need to understand all of the intricate nerves, muscles, glands that are necessary. And I'm going to credit my colleague, Dr. Christine Vaccaro, for this clitoris that she gave me last year at the national meeting. And I believe that you had some golden ones that were gifts too. I still think we need to give out these golden clitoris awards. But the issue with the clitoris is that it's not just a little button, it is actually a full organ that has 3 parts. And look how nice and 3-dimensional we are here. With the clitoris glands, that's the little tip. That's what people think, that is the clitoris. But no, there's more. There is a body that is very long, and there are legs on either side of the vaginal opening. And ladies and gentlemen, do you know that with arousal and engorgement and the appropriate sexual stimulation, this little complex thing can increase 50 to 300%. And I kid you not, because we have MRI data literally of women self-pleasuring, and they're also looking at erotic videos and stuff. MRI information, images showing this real engorgement that's happening. So what do we need to be able to have the functional clitoris and the stimulation that we need to get orgasm? Well, blood flow, blood flow, blood flow. We need to make sure that the tissues have enough blood flow so that when you stimulate the nerves, and there is a specific nerve, a branch off the pudendal nerve, and we can even test this, where you touch the clitoris and you'll see a little wink at the anus. That is called the clitoral anal reflex. All of this is intimately involved with sending signals through the nerves to the spinal cord, the dorsal root ganglion, back up to the brain and the pleasure centers of the brain to give you that sense of well-being, and then the physiological things that can happen with orgasm, which are transudative lubrication and excitement that can lead to actual contractions of the muscles surrounding the vagina. And some women will, with orgasm, will actually get a squirt, a little transudative squirt through some of the glands that are around the urethra and in the vagina itself. Sometimes that can come out of the bladder and it's related to urine, and there could be some bigger gushes that way. But the fact of the matter is, you need to have all of this, the anatomy, the nerves and the muscles, and the important neurotransmitters. Some of these are like nitric oxide, vasoactive intestinal peptide, things that cause engorgement and blood flow in order to occur. You also need to have a clitoris that's not covered over or damaged. So that's why I was talking about when you get some of these labiaplasties and some of the things that I fear young girls particularly, and even some postmenopausal women, they want to unhood the clitoris. They want to take off the skin that covers the body. That's really not good because a lot of nerves are coming in that direction. You want to trim up the lips, but then those lips kind of converge at the bottom. That's called the frenulum. So there's a hood, and then there's underneath this little glands, there's a frenulum. When you cut into that area and unroof things, not only can you affect the blood supply to this very important organ, you can also damage the nerves or specific branches of the pudendal nerve. So all of this comes into play, and it makes it a little bit harder when you become menopausal because things resorb. Estrogen levels make it so that the skin on the outside, as well as the lining of the vagina, really thin out. And that's when Dr. Kingsburg, and I know Dr. Vakar is going to be talking about this next, it's really important that we keep that tissue kind of healthy with some local estrogen. And there are many other formulations, and I know we've done several podcasts on this, and Christine will talk about it again, but it's important to keep that healthy and sort of thickened because you want to maintain that blood flow and that ability to get the engorgement, and hence the transudative lubrication that's necessary to have a pleasurable sexual experience. Now, I mean, orgasm is not the be all end all, although it is very nice to have. There's different models of sexual response. There's this linear model, almost like point and shoot, with excitement plateau, orgasm resolution. And then there's a circular model with just, all of this arousal, desire, everything that comes into a sense of well-being is also really important. I know, Cheryl, you would want me to focus on that circular model of sexual response, but my goal here was to talk about orgasm. So we're going to still talk about it. I don't know. That was a long answer to your question, which was, what do you do when you can't get orgasm? What you do is you go and talk to your doctor, and we take a look at things down there, and we talk about where this clitoris is located, because I can tell you that people may not exactly know, and they may not know how to masturbate. They may not know exactly where to stimulate in order to be able, and it's surprising me. I have patients that have been married, 30, 40, 50 years and to the same partner. And, yes, now the partner with the 50, 60, 70 rule has erectile dysfunction. So, she's never had, but there's nothing wrong with the fingers. There's nothing wrong with his tongue. There's nothing wrong with getting an enhancement toy to be able to place it on the spot because, with age, yes, blood flow goes, even your innervation kind of decreases with age. So it's going to take a little bit more stimulation. As Cheryl said, you're going to be a little bit more creative and, in order to be able to achieve it, but it is totally achievable. And it's definitely bliss when it happens for a lot of people. Now you're going to ask me about the G-spot. I know you're going to ask me about the G-spot.
I'm going to ask you about the G-spot.
You're going to ask me about the G-spot because everybody asks about the G-spot because it's considered the holy grail of the sexual response.
We'll talk about it.
Okay. I'm going to bring in my colleague, Dr. Vaccaro, to come in on this too. Most people get orgasm with clitoral stimulation. However, there are people who are they're very into vaginal penetrative sex and a spot along the anterior wall, a few finger breadths up. It's like, like this kind of motion along the anterior wall, which honestly, if that's called a vaginal orgasm, whatever, I believe, and I think a lot of people believe from MRI and even sonogram studies where people actually who are vaginally orgasmic have been evaluated with sonogram, placing their fingers of where that is in the vagina. That is their G-spot. And it actually correlates on the undersurface of the clitoris, because I say this is the glands on the back of it between the body and the crura. I believe that's where people are actually sort of stimulating. And so, we haven't had a lot of studies being able to map this out and find, that holy grail. But I do believe that some women, that is highly innervated and, it's a pleasure center. So most orgasms, as Dr. Kingsburg said, are achieved through clitoral stimulation at the glands level, but some people get a lot of pleasure with, having that other C spot stimulated on the underside, the G spot and the C spot. And there are devices that are designed for that. They're literally designed like little C's to stimulate both spots.
Well, we're moving right along to one of my favorite subjects. This topic is near and dear to my heart. I have many of our consultants, partners, staff members, and even my granddaughter who's dealing with endometriosis. Endometriosis causes pain and other symptoms in around 10% of women during their reproductive years, but is still relatively misunderstood by the general public. There's also a lot of misinformation that can cause confusion, fear about this condition. Can you talk about endometriosis and the impact on sexual health and wellness? And Dr. Iglesias, you have somebody joining us today. So
yes.
You want to introduce?
Yes. We work in Washington, D.C. at the MedStar National Center for Advanced Pelvic Surgery. In addition to having urogynecologists, we have minimally invasive gynecologic surgeons who are specially trained. It's a separate fellowship just on dealing with chronic pelvic pain and endometriosis. So I'm pleased to ask my colleague, Dr. Vadim Morozov, who's been my partner for nearly a decade here in Washington, and who is an expert. We've done a lot of cases together. So when I saw that I had this question, I was like, Patty, we need to get somebody who really knows what he or she is talking about. And I've got, 4 partners, and we've got 3 fellows, who are just dealing with this. So Dr. Morozov, want to introduce yourself and welcome, and thanks for coming on. Really appreciate it.
Thank you, Cheryl. Let me know if you can hear me well, because I can always switch the mic. Perfect. Well, it's absolute pleasure to be in a podcast. So endometriosis, as you mentioned, 10%. Some people will say 15% of reproductive age women, depending who you quote, but I guess 10% is a good number, suffer from that disease. It's still an enigma. I mean, we know quite a bit about it. We've learned quite a bit about it in the last 20 years, but we still don't understand truly what causes it, how it progresses. Why do some women have a lot of disease and a lot of pain associated with that? Other women have a little bit of a disease and a lot of pain. Others have a lot of a disease and almost no pain, right? So if you deal with that for quite a bit of time, you realize that it's such a wide spectrum of issues that women come with endometriosis. And one of the biggest, of course, concerns, and I guess on every woman's mind is, will it affect my fertility, right? Or sexual health, or an ability to conceive and carry the pregnancy to full term? And the short answer as far as endometriosis, possibly, right? So it's a chronic inflammatory disease. We don't have cure. We've come up a long way. We can offer some way to deal with it. And there are surgical management, which is considered the gold standard. And of course, there's some medical management that controls the symptoms associated with endometriosis. But there is no cure. We don't know how to eradicate that disease. And interestingly enough, I mean, I talk about endometriosis, and I'm part of the Endometriosis Foundation and the March on Endometriosis. And it's kind of a working joke that if we had a condition, think about it, that affects 10% of male population, that prevents them from having sex, having normal lifestyle, going out and working and socializing with their friends, we would have an act of Congress tomorrow mandating $10 billion to be invested in this disease and eradicate it, right? But because it's women and a population that sort of like, you know, your grandmother had this problem and the grandmother had this problem and your mother had this problem, suck it up. So I think it's very underrepresented. And going back to fertility and the sexual health, obviously the major symptoms is painful periods, painful intercourse, you know, pain in between the periods. And then we're talking about if the endometriosis becomes really bad, if the disease becomes stage 3 or 4, the highest stages of the society, it will affect fertility because it causes scar tissue, it causes the local inflammation in the pelvis, it will affect the tube, the fallopian tubes, it will affect the ovaries. And we see, as Dr. Iglesias mentioned, we practice in DC, so there's a Shady Grove Fertility, I think 20 offices all around us. It's hard to underestimate how many patients we get referred to us from Shady Grove Fertility because they obviously seeking care for the infertility treatment, and they come to us saying, I have endometriosis, I have endometrioma, I've had 3 laparoscopies in the past, and I've been diagnosed with endometriosis. And my fertility doctor wants now you to fix whatever endometriosis problem we have so I can go back and then, you know, do my IVF or IUI or whatever they're planning to do there. So it's definitely a problem. We technically, there are probably 3 different diseases that are lumped together in endometriosis. 3 different theories of how the disease develops. Most commonly known is that's called retrograde menstruation. Small amount of menstrual blood gets thrown back through the tubes and then becomes endometriotic lesions. A lot of people in the endometriosis community don't like that explanation. It's very simplistic very often, right? Because almost 100% of menstruating women will have that retrograde menstruation, and only 10% will develop endometriosis. So what happened to the other 90%? How come? And if all of them do that, only 10% develop it. So there's something else is going on. There's definitely immunologic theory saying that there's some disturbances how that endometriosis gets cleared. And then, yes, every woman who menstruates have retrograde menstruation, but then normal immune system kicks in and clears up the endometrial cells from peritoneal cavity, and you never develop the symptoms. And then women that do have endometriosis, that immune system malfunction at certain level. We don't know where, but it's clearly, we also know that women with endometriosis and chronic pelvic pain do have much higher risk of other autoimmune diseases, right? So like fibromyalgia, psoriasis, and everything else that comes with it. So there's definitely some there's a big sense in the community of endometriosis pelvic pain specialists that there is definitely some sort of underlying immune problem. We just can't pinpoint it yet. We can't just put our fingers in it and say, oh my God, we found that mediator, that marker of autoimmune inflammation, and that if we can control it, we can control endometriosis. But there's this kind of a impending sense that it's definitely going in this direction. And then there's, of course, deep infiltrating endometriosis or rectovaginal endometriosis that doesn't get explained by retrograde menstruation. That's probably some sort of a genetic modification. We call it Müllerian anomaly, or embryologic changes that happened while the baby was developing. That baby girl was an embryo, and then those cells never made it to where they're supposed to be, and they end up in those weird places like where not. And interestingly enough, endometriosis was found literally in every organ in the body except one. Spleen was the only organ that they were never able to diagnose the presence of endometriosis and endometrial implants. And that again points to the fact that it probably had autoimmune components. Spleen just so effectively cleans up the endometriotic implant that they've never been able to establish the presence. They found it in the brain, in the heart, in the lungs, in some totally weird places, in the eye. There've been reports of endometriosis found in the eye of people, but spleen was the only one. I thought I was always fascinated by that finding.
That's like a good Jeopardy question.
Right. Yeah, absolutely. So that's probably that deep infiltrating endometriosis is completely different disease. And then, of course, there are endometriomas, right? So the chocolate cysts over the ovaries. And that's the one that we see a lot with reproductive problems. People coming up saying to us, I can't get pregnant and I have this endometrioma. And that's like a separate disease by itself. It's definitely not retrograde menstruation. It's probably not related to the immunologic or embryologic development. It's what we call the coelomic metaplasia theory, where the surface of the ovary suddenly becomes changing and turning into this chocolate cyst that's otherwise known as endometrioma. And because the cyst is so large as a rule, and it creates a whole bunch of local inflammation in that ovary, of course, those women don't ovulate. Now they have the problem of ovulation, that ovary is not functioning. Very often they're bilateral, so both ovaries are involved. And in gynecology, we call them what's called kissing ovaries. The ovaries are so large that if you look at the ultrasound, it looks like each ovary is touching each other with those endometrioma cysts. And the other problem is, and actually one of my colleagues who used to be my fellow, Dr. Hazen in Georgetown, now doing research, we also found that those endometriomas inevitably start leaking those chocolate material. Once they reach a certain size, 4 centimeters, that chocolate fluid starts micro-seeping through the wall. And that acts as a glue. Everything sticks to it. The bowel sticks to it. And then the ovary sticks to the pelvic sidewall. The ovary sticks to the uterus. The tube then, of course, gets stuck into this conglomerate of that endometriotic inflammation. And then, of course, it creates the infertility problem. I'm not even talking about pain and inability to function and having horrible, painful intercourse, because, of course, it feels when the patient comes to us and we ask, do you have pain with sex? And almost universally say yes. And you always ask the question, so does it feel, tell me how it feels. And she said, it feels like when we're having sex, it's like he's stabbing that point, one particular sharp stabbing pain, like there's a knife. And it actually, when you examine and you do very thorough pelvic examination, you can almost get the same response when you feel it. And she goes like, that's exactly how it feels, because you as an examiner, as a gynecologist, feel that tender spot. You're hitting that spot with your fingers when you do pelvic examination. So it's a big problem. It's a big disease. We're working on it. There's a whole bunch of research. As I mentioned, surgical management's considered the gold standard because it allows you to diagnose it 100%. You either visualize endometriosis or you can excise the lesion and send it to pathology for endometriosis. The laparoscopy is also curative, right? So if you have enough skills and enough training, when you go in and you see bad disease, you can excise, you can clear up, you can restore pelvic anatomy back to its normal sort of shape, and that allows the person to either have normal sexual life, normal regular social life, allows an ability to become pregnant again in the future. There is some medical management that are relatively new, couple of years. The problem with the medical management is that it addresses the symptoms, right? It doesn't cure the endometriosis. What it does, it helps a woman a little bit with symptoms like pelvic pain and intercourse, but really doesn't do anything as an underlying condition why she's having this problem, why she's having painful intercourse or painful, such a debilitating menstrual cramps that you can't get out of bed. The newest research in endometriosis is, of course, trying to find markers of the disease. Can we diagnose the disease without cutting in somebody, without subjecting the patient to surgery? And we are part of the multicenter study where we're looking at those markers in the blood. They call microRNA fragments. And there's actually a potential to get those markers out of a saliva. So you can do like a cheek swab, very simple, get the swab out of the cheek and send it to laboratory. And they can look for those microRNA fragments, and they're saying it's pretty much, it's 85% sensitive. So pretty good for the test, right? That is not invasive. You can just do the quick swab in it, send it up to lab, and with it 85% of accuracy, which is not what the sensitivity is, but for, but pretty good to get you like, yes, there's 85% chance that your condition is endometriosis related. So that's where we are right now.
How do you as a doctor determine what stage the endometriosis is in?
Right. So there are 4 stages based on the revised American Society of Reproductive Association. It's 1, 2, 3, and 4. 1 is the mildest, and the 4 is the most severe. And there are actually tables that allow us to establish whether it's a stage 1, 2, or 3, or 4 based on the size of the implants, where they are, how many, how deep they go. I'll give you an example, but the staging system is a little bit funny. The staging was developed by ASRM specifically for the purpose of fertility, how much it affects the future fertility. It doesn't really do much for us as pain or any other symptoms. A good example is that just the presence of endometrioma automatically makes you stage 4 disease, right? So without anything else, you don't know much. So if you just have endometrioma, it's stage 4 by default, which is sort of like doesn't make sense, because it's one thing to have endometrioma, and that's completely a different thing to have deep infiltrating rectovaginal endometriosis, which is also stage 4, for example, right? So
isn't it interesting, Vadim, how sometimes people can have this stage 4 and be totally asymptomatic? And
absolutely.
then people can have very early stage and have severe debilitating pain, and you can't see it. And I think that has to do with where this is affecting in terms of the nerves, you know, the sense.
Right. So staging, as I mentioned to us, staging by itself doesn't make much of a difference. What we've seen, as Cheryl is saying, is we go in and patient comes to us, for example, I don't know, 25 years old, severe debilitating dysmenorrhea, meaning horrible periods, like doubled over for 5 days every month. Sexually active, says it hurts like hell every time she has sex. We go in, we do the laparoscopy, and we find like 3 small implants, peritoneal, right? So, but the interesting part is that those 3 small implants create so much inflammatory reaction, and it causes what we know the neovascularization and neoinnervation, those C fibers that are ingrowing toward those implants become hypersensitized. And actually, there's a lot of research that's done in the past that nothing's new about that the density of those C fibers are much higher all around the endometriotic lesions. So the new nerve endings are growing toward that lesion, new blood vessel supply establishes itself. And it looks like just, yes, 3 small implants, and yet she's in so much pain. And funny, we remove those implants and they do extremely well.
But there's also like opportunities for prevention if we can stop periods, because you don't necessarily need a period every month. And now we've got newer technologies that are actually focused at the mitochondrial level, nitric oxide release, et cetera, et cetera.
Right. The stopping the periods work to a certain extent as far as controlling the pain, right? It doesn't do much for cure of endometriosis. There is a potential that if we truly believe that a lot of endometriosis come from retrograde menstruation, then yes, the fewer the periods the woman has, the lighter they are, the shorter they are, the sweeter they are, whatever you want to call it, the better her chance of not having a relapse of endometriosis. That's if we truly believe that what that particular patient is having is a retrograde menstruation peritoneal disease, right? Because if we're talking about endometrioma or deep infiltrating endometriosis, I mean, stopping the period is always good to a certain extent, right? I don't know I mean, occasionally we see a woman that says, oh, yes, I like to have my period every month. It makes me feel good. But as a rule, as a gynecologist, most women don't miss their periods that much, right? So if you can safely and effectively stop their periods from happening every month, majority of women will say, oh, great, love it. I mean, it's a great thing not to have a period and not to have this pain.
But even if you use some of the other drugs that are designed to stop periods at the hypothalamic level, the problem is you can't use them for so long because it's so bad for your bones. It will
That's
put
correct.
you in
So-
a state of menopause.
Right.
And so that has to be used balancing
Right.
the long-term
So
effect.
what Dr. Iglesias is referring to is it's the centrally acting generate antagonist, which is a new kind of drugs that's been on the market for about 2 to 3 years, and they do block the release of FSH and LH from the brain. And in essence, they cause hypoestrogenic state. So you lower the estrogen. We know that endometriosis is estrogen dependent disease. If it's not developed by the estrogen, it's definitely driven by the estrogen to progression. So if you can lower it, then the symptoms get better. But of course, the side effects come with that. There is no free lunch, right? So hot flashes, mood swings, if you stay in that for too long, osteopenia, osteoporosis, those things, of course, associated with that. But that's sort of a new medical management of endometriosis. But again, we have to keep in mind, and we educate our doctors and our colleagues, that this is to a certain extent a Band-Aid, right? You're treating the symptoms of the disease. You're not treating the disease. So you still have an endometriosis. You still have a bad disease that is chronic and we don't have a cure. But yes, I can put you on the medication and the symptoms might get better with it.
Do you foresee a cure for endometriosis?
Well, I think we have to figure out what causes it. Again, why does 10% of women have it? What is it about those 10% of women specifically that predisposes them to developing this disease?
I agree with you. I think it's more than 10%. I think it's something shameful. Women don't talk about, they don't seek attention for it. And I do think that it's higher because I see it just with our consultants in our office, even family members. And so, and I'm really kind of angry, if you want to know the truth, that we as women have put ourselves on the back burner and have said, oh no, take care of everybody else. And now watching somebody go through this is really, it's very difficult.
Yeah, I'm sure it is. It's a tough disease to deal with, especially if it gets to the bad stages, as we say in stage 4 and 3, it becomes disseminated, multiple organs involved, right? So it's so much easier from a surgical perspective to deal, for example, with a very superficial early disease than go back and deal with this distorted anatomy where the bowel is stuck to everything else and everything else is stuck to everything else around it. So
yeah, well, is the general way to kind of treat this, is it like IUD or what?
IUD helps to alleviate one of the symptoms like severe dysmenorrhea. I think progestin containing IUDs such as Mirena or Skyla, there are at least a few of them on the market nowadays, really helpful as far as eliminating the symptoms of really painful cramps associated with menstrual cycle. But past that point, they really don't do much else. As with any conservative management, doesn't matter which way you go, I think everybody needs to think about this. If you have endometriosis, let's say we think you do have endometriosis and you have endometrial implants, no matter what we do conservatively, those implants don't go away. They never disappear, right? They change their characteristics. Progestins are known to cause what we call desudulization of endometrial implants, meaning they dry them out. But when the implant dries out, it's still there. It still pulls that peritoneum together. It pulls those nerve fibers in. It still has changes the anatomic surface of the pelvic organs. Now, it doesn't bleed every month, right? It doesn't have this monthly inflammatory response, but really nothing happens to that implant. You just sort of put the lid on that, right? With a high dose progestin, for example, the symptoms get better, but the disease is still there. And that's the problem with addressing it.
We need research.
That's why we need, we have, when you asked me to speak about this, I said, I want to talk to people who like do this day in, day out, and we operate a lot together, but I do not do this, the deep dissections and things that are you want to do it nerve sparing, because you don't want to treat and then end up worse than the original condition. Say you can't pee or poop or have orgasm afterwards. So it's a delicate area. Lots of work needs to be done. Patty, I'm glad you're bringing this to the table to discuss.
I am too, because, I've witnessed, again, having employees in here that staff members who have not been able to conceive. Then I've had my 18-year-old granddaughter who's been told that she needs to retrieve her eggs, save them, freeze them. So I just think that this information is important so that women, mothers, whomever is helping this person through this is able to get this information that they need. I mean, I remember watching I think I had Grey's Anatomy on one night, and there was, I think, Sherelle, you and I talked about this, where I said, this lady had endometriosis wrapped around her heart, her lung, and you're like, oh no, that's really true.
Yeah,
It's
diaphragm.
That's scary.
And people bleed into their brain. It's in the meningiomas and the meninges. So yeah.
Right. Women have bleeding in their lungs, they have hemothorax, as during the menses, they have catamenial pneumothorax, meaning every time she's having a menstrual cycle, that menstrual cycle happens inside her lungs.
Yeah, and we have to dissect things along the lining of the lungs, along the diaphragm itself, inside the heart. Multiple cases of it eating into the bladder and the bowel, and you get, a lot of problems with, bleeding. So it's an enigma. We need to have a separate, conversation about this and bring in a lot of experts, including basic scientists, because I feel like, what Vadim is talking about, all the basic science theories, we need more information on that.
I agree. I do think that we do need a lot more research, but I do think we need to do a deeper dive into this, and maybe even bring on some patients that have gone through this, because people who are listening want to know that they're not alone. They want to hear maybe some of the things that is happening in their medical health.
Right.
So
and we should field some questions from the associates that are from the women that they encounter. And we can also bring in, there are a lot of advocacy groups specifically, and physical therapists who are literally trained just for endometriosis as well.
I would love to do this. So I think this is an important topic. I hope this year that we grant something in endometriosis, hint, hint, hint.
Yeah.
Yeah.
We're on the board. We can make that happen.
Yeah. You are on the board. You're the one that makes it happen. So I think
If anybody can make it happen, that's Sherelle.
Yeah, this woman right here.
I really appreciate you coming on. I hope that you join us in our further discussion. Thank you so much. You've brought a lot of light to the subject, and I think that people have heard endometriosis, really not knowing what it's all about. And I think a lot of times when you experience it or have a loved one, it's a difficult thing to watch someone go through. So I'm going to be one of the first ones that are going to rally for more research on this. So thank you so much again. And I can't wait to meet you again and spend time with you in the future here.
My pleasure. Come to visit us in DC.